we've introduced this name psychologist that encompasses a psychological therapies coordinator role. So someone has a specific named responsibility for knowing what interventions have been identified as needed, when those are planned to be delivered by the service, and when a service user will access them. So those again trying to join up each individual service user with organisational planning structures. And alongside that, in some ways similar to the points that Kate was making about risk assessment, to integrate that into an HCR20 coordinator role, that the psychologist would not be specific for doing an entire HCR20, for example, but that they were responsible for making sure that it was done, and specifically picking up on the point about structured professional judgment, that a formulation would be the responsibility of the psychologist working with the service user, and that would permeate into care plans. So there should be no risk identified that is not also an identified treatment need. And in that way trying to integrate the notion of personal recovery and offender recovery tasks within a secure recovery role. So I'm going to hand over to Jonathan.
So the heading secure escorts and transfers, but I'm not going to go into too much detail about the whole sort of gamut of things that are involved in that, because obviously there isn't enough time. Background and purpose, as ever, I'm afraid, this sort of thing came about for me in other organisations I was working at with colleagues, and indeed for us at Sussex, when we realised that there were some problems, especially when we really think about the fact of going out of a secure unit into a non-secure area, a public space, even in a vehicle which is secure. It's nowhere near as secure as it would be when you're in your secure premises. So there is more risk there, and even if we look at it carefully and realistically, we've got to realise that should something go wrong, which occasionally has happened sometimes in parts of the country, then the impact could be great for the service, for the general public, etc. There'd also been some problems in the past in other organisations I've worked at. We'd had our staff coming back saying that they felt treated very badly, during a transfer, for example, when they've gone to another institution, and that sort of wasn't always the case. So there was clearly a lack of consistency in certain institutions with the way that their staff went about the business of receiving from our staff and so on. But we felt that really, rather than put in a complaint and perhaps make make relations difficult in the future, it might be better to actually meet, talk about things, iron out any differences, and try to work forward together with the relevant institution or agency. Developing the transfer protocols themselves then stem from this sort of work, and simple things led to it happening. Making contact. I think that issue of who you contact is important, and if you can identify a good gatekeeper in services, then that's helpful. And certainly in my work on this in the recent past, I've been very lucky that I've actually known people, because I've worked with them previously in different trusts and hospitals, but that's actually been very, very helpful just to exploit, in a positive way I hope, that knowledge of individuals, and either they themselves or they can direct me to key people. We build into the work and the discussions the idiosyncrasies of the different services. So if you think about going to a prison, for example, a transfer to prison, it's quite straightforward, even though we've got lots of different prisons and they're not all the same, as we know. But things are straightforward there, because you don't drop someone off outside a prison. You're always going to go into a vehicle lock, and they've got these basic arrangements. But if you look at going to another secure unit, you see a range of different arrangements. And in some cases, including the last service I worked at with the medium secure service, people had to go outside the building into essentially public space to get into the vehicle. Now, where I am currently, they have a vehicle lock which is relatively discreet, and that's quite helpful. But idiosyncrasies like that need to be arranged if you've got a specific transfer protocol with a specific hospital or unit or whatever. In the protocol, what would be involved? Things like how we prepare the staff. We always have a briefing. It's better if they've been given information and training in advance, but having a briefing, letting everyone know what will happen pre-transfer, things like estimated time of arrival, arrangements on arrival, and things like this. A key issue is the transfer of the responsibility, because on the occasions, what will happen, most occasions of course, is that we'll have people coming into an institution with the patient, and they're on the premises that are, the receiving organisations. So if, to use a simple example, handcuffs are used, who has responsibility for that patient at that time? And really, the cut-off point often would be handcuffs if they were used. So if someone comes in the handcuffs of the transferring agency, they remain primarily their responsibility until the handcuffs come off. But of course we need to make sure that the people receiving the patient are satisfied that things are in place before the handcuffs come off. So it's little things like this, just to make sure we're ahead of the game, everyone knows what's going on. And key issues with regard to things like benefits would be that confidence has increased. Staff have reported greater levels of professionalism that comes from that confidence, but also patients, service users, whatever they're called in your institution, they've been asked informally, what's it been like for you? How was that? How did it go? And they've reported that they feel that the staff look professional, feel more professional, just through having that confidence and being well organised. I think a last point from me is just about the benefits for the agencies, because I think that prior communication plus frequency of repeated episodes and that sort of Bible, if you like, of coming back to that protocol has helped to improve relationships in some areas where it was difficult, as well as smoothing the path. So we think overall it's benefited patients and staff by having this sort of thing.
Okay, my final time. This is just to finish this off with. So in terms of length of stay, the benefits, I've only done the graphs for two, which was the top is male medium secure, and the gap is the change in financial year, and the one below is women's medium secure. But just to give you some summaries, we had our benchmark was from the end of March 2012. So men's medium secure average length of stay at that point was 358 days. October this year, 2013, was 345.6, a reduction of about 10 days, a little bit less. Female medium secure was in March 2012 592.8 days, and is now 496.8. Women's low secure, it was 756.5, really long length of stay, and October 2013 was 377.4. And men's low secure was the smallest change, was 444.6 in March 2012, and is now 446.4. So obviously that's a real blunt instrument, but just as kind of indicator. We would very much like to thank our colleagues who couldn't be here today, Dr. Mike Lawson and Gary Davis-Ebsworth, who are psychology consultant and nurse consultant who did lots of the work and led on lots of the work in terms of CPA. And that's us.